Very good morning to all of you, and welcome to this keynote session on day 2 of the conference. I would like to introduce the speakers in this session. We have Dr. Rushi, who's an associate professor and HOD at Department of Clinical Psychology, Center of Excellence in Mental Health, RML Hospital, New Delhi. She has worked in various leading government postgraduate medical colleges and hospitals and psychiatric institutes for more than 20 years. She is recipient of various prestigious awards, Life Empowerment Award for Holistic Education Leadership, AICRA Award, and Women Health Award. She has various publications in national and international journals and has published national and international books too. She has been consultant on leading national media, both print and electronic, like DD News, Doordarshan, Kisan, NDTV, Rajya Sabha Channel, India TV, and Sansad TV. She is also Honorary General Secretary of Association of Clinical Psychologists. Today, we are going to hear Dr. Rushi on the mental health policy in India. And here I would like to also introduce our second group of speakers from Project Sangath. Project Sangath started in 1996 and has grown into one of the world's recognized mental health research NGO. Headquartered in Goa with hubs in Delhi and Bhopal, the organization has conducted many research projects in partnership with state governments, collaborating with organizations such as Wellcome Trust, NIH, MacArthur Foundation, MRC, and Tata Trust. They have received national and international awards in recognition of their innovative research. In the team of presenters from Sangath is Mr. Deepak, Director of Projects. He is trained public health professional with over 13 years of experience in leading large-scale trials. We also have Mr. Azaz, who's Director of Interventions and Training at Sangath. He's trained in psychology. Just a minute. Yes, this one. Yes, sorry. So he is trained in psychology and has more than 15 years of work experience in implementing and research, end-to-end health program management, capacity building of mid-level health professionals, teaching and psychotherapy. We also have Mr. Abhishek from Sangath, who is a senior research coordinator at Anand. He is trained psychologist working in the field of global mental health research. And we have Ms. Lochan, who's intervention coordinator, Anand. She is anthropologist and public health researchers with her research interest in intersection of gender, health, equity, and policy. So as you can see, we have quite a broad spectrum of eminent speakers in this session. I hope the attendees will enjoy. So first, I would like to invite Dr. Ruchi. And Dr. Ruchi, you can share your screen now. You can see if you can share and so we have about an hour, Dr. Rushi. So we'll time it in a way that we are left with about 15-20 minutes for question answers in the end.
How much time I have to?
Maybe 20 minutes, if that's fine.
Okay, sure, that's okay.
Yes.
So a very good morning, everyone. So first of all, I would like to thank the organizing committee for inviting me. It's really my privilege to be a part of your conference and to talking on this very pertinent topic of national mental health policy today. So as we always talk about that when this national mental health policy came in the forefront, so we always used to say that, now we can go for new pathways. Because mental health policy, when it came, so it was particularly describing the value and objectives and strategies of our government to reduce the mental health burden and improve the mental health. So the focus was not only to decreasing the mental health burden or to preventing the people from mental health illness, but also the promotion of it's not just the absence of a psychiatric disorder or mental health issue. And that have been given on the promotion of mental health. future in terms of mental promotion. It helps to establish a blueprint for the prevention and management of mental illnesses and also the rehabilitation of people with mental health issues. And of course, the promotion of mental health in the community. So it is particularly specifying the standards that need to be applied
I think Dr. Rushi is having some network issues. Can I request all the attendees to please stand by? We are trying to figure that out. Yes, welcome back, Dr. Rushi.
Yes.
We lost for a moment. Yes. And your voice.
Am I audible?
Yes, now you're audible. Yes.
I'm audible. Okay. I was trying to connect again, but now I'll cancel that. So my screen is. Can you?
Ma'am, you might want to
Not yet, ma'am.
Video because that will give you better bandwidth because your bandwidth is probably low. So if you switch off the video and keep the audio one on, it might be a little better.
See my screen?
Not yet, ma'am.
That also the
Ma'am, we can't hear you or neither can we see the screen.
you hear me now?
Dr. Rushi, do you want to figure out the problem? I mean, we can invite Sangath team to present and then probably.
Am I audible now?
Yes, ma'am, you're audible, but then the voice starts cracking up. Probably it's some network issue.
If it is okay now, then we can proceed. Otherwise, then you can wait.
Okay.
As you say.
Oh, I just don't want to rush you. I mean, in the sense, if you are trying to figure out the internet connection, then probably we can call you later. And
because
in the meantime,
because I have to connect by this internet connection only. I don't have any other option here.
Okay, ma'am.
So I'll just try my best to just coming to the point. So I was just telling you all that the first draft of National Mental Health Policy that came into existence and which was prepared in 2001, and it was prepared in 2001, but it came into existence in 2003, and it provides the necessary conceptual framework for achieving all the goals. So in my presentation, I'm just going to talk about the vision of mental health policy, the values and principles, goals, cross-cutting issues, and strategic directions and recommendations for actions. So while coming to the vision is very clear, that is to promote mental health, prevent mental illness, enable recovery from the mental illness. So for the people who are already suffering from mental health issues, or they have been diagnosed with some disorder, so the effort is to help them so that they can reach to that recovery stage, and to promote the destigmatization and desegregation from the community, and ensuring socioeconomic inclusion of persons affected by mental illness by providing them accessible, affordable, and quality health and social care to all the persons throughout their lifespan with the right-based framework. So it has such a wide perspective, and when they were talking about the vision, and they have the policy has been come into existence with this broad vision. So certainly there is a depth in all those things, and there are certain values and principles which are attached to this policy. So one is the equity, justice, integrated care, evidence-based care, the quality of the care, and participatory and rights-based approach. So, this was the transition from the previously existing traditional approach, when a lot of emphasis was on the treatment part only. So now they're talking about they just talk about the participation of the person disorder, and given to the human rights. Governance and effective delivery also have been to training programs. So what training programs are running across India, whether it is MD in psychiatry, or it is MPhil in clinical psychology, or there is diploma in clinical psychology, or any program which is related to mental health, a lot of emphasis has been given on the quality check also. So it's talking about mental health in a holistic way. And coming to the goals of National Mental Health Policy, the first and foremost goal was to reduce distress, then disability, exclusion, morbidity, and premature mortality, which is associated with mental health across the span of the person. And to enhance understanding of mental health in the country, and to strengthen the leadership in the mental health sectors level. The main objective is to provide the universal access to mental health care and increase access and utilization of comprehensive mental health services by persons with mental problem. There were around 9 objectives which were formulated. They were preparing the policy. So I'm just trying brief to giving you a picture of what were the other objectives. So the third objective was to increase the access to mental health care, especially to vulnerable population, with including like the homeless people. So when I was working in Mbas in around 2003 to 2013, so we used to run a clinic near Jama Masjid for the homeless population, where the judicial magistrate also used to come, and together as a team we used to see the patient. And these all homeless people. So one of my efforts other so, but I have to emphasize here from years. And first area. So the whole idea of the district mental health programs came into existence. So the idea was to providing mental health services to those remote areas where especially the people who have difficulty in accessing the mental health care facilities, especially the tertiary care facilities, and who are educationally and socially backward classes, to reduce the prevalence and impact of risk factors associated with mental health problems, and to reduce risk and incidence of suicide and attempted suicide. A lot of programs at the national level are going on. Even currently, I'm also having 1 or 2 projects one by the ICMR, another from the Pittsburgh University. So we are particularly working on the prevention of suicide and other objective was to ensure respect for rights and protection from harm of people with mental health problems. So when this Mental Health Act 2017 existed, human resource of mental health. So a lot of new programs have been started across
Dr. Rushi?
India in the field of mental health. Yes, yes.
Dr. Rushi, sorry to interrupt, but if you can switch off your video, the voice will definitely get better. Like your own video,
Okay.
not the PPT. Yes.
Okay, so PPT is not required.
No, PPT
Okay.
is fine if you can switch off your video. The button you
Acha.
see, the start video button, if you can just, switch
Okay,
that off.
okay, I'll see, I'll see.
Yes. Otherwise, your voice is perfect, but at times it starts to crack. So that will be better if you can.
Yeah, I'm just trying.
On the bottom leftmost corner, there are two buttons. One is mute, the other is start video. So if you can click on your...
I'm able to see only the mute one.
So there, can you see your start video button also?
No, it's not apparent. Then I have to first. I just need, yes. Now I can do that.
Okay.
And share the screen.
Yes, ma'am.
Yes. Is it visible now?
Yes, ma'am. Thank you. And
Yeah.
your voice is also better, much better.
Yeah.
Thank you so much.
And the last, foremost important objective was to identify and address the social, biological, and psychological determinants of mental health problems and to provide appropriate interventions for that. Cross-cutting issues were stigma, right-based approach, vulnerable population, adequate funding, because there are a lot of problems related to funding across India. So whenever they want to start any program for rehabilitation, or they want to just initiate any action for the prevention and promotion of mental health, so they find problems in funding. And there are a lot of people who come under the vulnerable population, like child, women, and all. So, and the homeless people, socially backward people, there are not much programs for them. And because there is a lot of stigma which is associated with mental health issues, so those are also very important cross-cutting issues which need to address. And the other issues are of institutional care and this thing, research also. So, so the NMHP was being energetically implemented with the educate budgetary support in the 10th 5-year plan, like I have discussed. So with all those goals and objectives in these 5-year plans, that has been successfully implemented. But yes, there are many issues which are related to those, like the senior citizens suffering from the severely disabling diseases such as Alzheimer's disease and other type of dementia like Parkinson's, depression in the late onset, and other psychiatric disorder. There is not much intervention and rehabilitation services for that. It is not particularly addressing those particular segment, because we have seen after COVID-19 that a lot of people, the old age people who are left behind, there is no one to look after them, and because their cognitive skills are declining day by day, they are feeling isolated, they have loneliness. A lot of programs need to be addressed for their mental health care. And there are victims of child sexual abuse or marital domestic violence, dowry-related ill-treatment, rape and incest, and the children and adolescents affected by the problems of maladjustments or other scholastic problems, depression, psychosis of early onset attention deficit hyperactivity disorder. Usually we call them ADHD. And the failure from the examination or other environmental stressors. So, it's also talking about a lot of psychosocial stressors also. There are victims of poverty also. And yes, return from the natural or man-made disasters such as earthquake, families, or for terrorism. Recently, we had COVID-19, which had a serious impact across the world. So the special attention to the specific needs of the children or the friends by such disaster has to be given. National mental health policy was first for the military in 1983, and it was revised in 2002. And like I told you, that it came into existence in 2003. Objectives we have certainly talked about in detail in the beginning. So I'll just come to the special initiative it is taking. So the special initiatives, what has been taken over by NPPA is to integration of mental health with the primary health care. So they are trying to collaborate mental health services to the existing healthcare services. So the general physicians, a lot of emphasis has been given on the training of the general physicians, so that they can, they can rule out in very initially the mental health issues which may take the disability or later on. Because we have scarcity of human resources, we just need to train those people. Then construction district hospital where only psychiatry OPDs are running. Under the DHP program, a lot of districts who have initiated those OPD services. So a lot of emphasis has been to start IPD services. Essential equipments in all the state-run psychiatric hospitals. So a lot of funds have been released to provide the equipment, to provide the medication, and they will be supplying to the psychiatric hospitals who are taking care of the mental health of the people. Then the extension of DMHP in additional 5 districts. So primarily it was viewed that that will be given to the 5 districts, but there is because there is a need also, and a lot of efforts have been put in the expansion of those services. Then organization training program for medical officers, paramedical workers. Like the GP training program in 2005 and 2006. From that period only, we used to, when I was in Institute of Human Behavior and Allied Sciences, so we were involved in many the training programs for the GP. So the private practitioners or the practitioners who are working in some government organization, they just used to come for the training program, and we used to train them how to identify, depression, anxiety, schizophrenia, personality disorder, the common mental disorder to severe mental disorder, and what help, what treatment they can provide them, so that there is no treatment gap on the part of the patient, because generally because of the stigma, because of negligence, and because of lack of awareness also, the people, they just get afraid or they just feel shy coming to the mental health hospital, so mental hospital or the psychiatric OPDs. So if they are getting the treatment in the general healthcare system, so there is nothing best like that. So if you will review this policy, you will see that this is the first mental health policy of independent India. And mental health problems, not just illness, but it includes all the psychosocial issues. So if there is some stress because of the domestic violence, there is some stress because of the scholastic problem, the child is having difficulty in reading, writing, the child is having some emotional behavioral issues. I'm not talking about the disorder. So in every family, you will see that our young generation, they are having one or the other kind of mental health issues. In the schools also we have seen, like, because I had an opportunity to, by the Ministry of Education, to preparing the module for the teachers. Again, because there is a scarcity of human resource, training the teachers so that they can screen out those mental health issues very soon among the children and adolescents, because it is seen that 75% of the mental health issues they emerge in adolescence. So, recognizing the mental health problems are high in vulnerable population and disadvantaged. Recognizing this fact, they have trying to incorporate the services to those disadvantaged sector also, like the homeless population, and because it's a rights-based approach, and funding of mental health care is emphasized not as an expenditure but as investment and social rights. Prevention and treatment of the mental health problems is talking about the institutional care, community care, assisted care, independent. Now, because think about that, we should go forward. We should look forward beyond the institutional care. Anyway, going to the family so that they can get their care at the family level is being thought of at the family level. Support for the family members and the caregivers have been given, and this is talking about the holistic mental health care. So it's not only the one domain that we are just talking about the reducing or the prevention of mental health issues. So, of course, the research and strengthening the leadership in the mental health sectors of all the levels. But because with all the advantages, there are some disadvantages also. And these drawbacks are that it is aspirational and difficult to implement. Because, the goals are so broad, there are so many goals involved. So it's always good to have big dreams, but when if you see the practical aspect, we are still left behind in so many goals and aspirations. So there is no time frame and plan. So a lot of objectives were formulated, but it is not mentioned that that what is the plan. If you are planning to open the training courses, that how long we have to go this way that we can achieve that level that we are having adequate number of health professionals. If you will see the ratio of the demand and supply of the country, there are too many strategies and recommendations, and psychosocial issues also they have not defined. That there are broad spectrum of psychosocial issues, but they have not defined those. Almost all ministries and stakeholders are involved. That is also one of the major drawbacks. Because when they were formulating the policy, they did not involve all the stakeholders. But when they are talking about the work done and their plans or the rehabilitation plan or incorporation of different stakeholders, they have just declared that this is the responsibility of all the stakeholders. Users are the general population. So they're talking about providing those, facilities to 138 crore of people. So that is also something difficult to attain. Another drawback is that the universal interventions for psychosocial problems and health promotion lead to dispersion of responsibility. This is also a human psychology that we will just try to displace our responsibility into one another. Like, I'm giving you a very simple example that the parents will say that this is the responsibility of the school to take care of the mental health of my child. The teacher will say that it is the responsibility of the parent. And now we are, as a policy makers and as administrators and mental health professionals, we say that this is the responsibility of all the stakeholders, whether it is parents or teachers and even the teachers. or the principal, the role of a principal, role of a teacher, counselor, parent, everyone's role is very important. And this may lead to fragmented policies, poorly defined roles and responsibilities, weak follow-up and monitoring mechanism, right? So this is very important and very pertinent that with these kind of roles and objectives, we may have fragmented policies and ill-defined roles and responsibility. So when we talk about the evaluation of this mental health policy, so the effectiveness of mental health policy means that we are addressing, we're talking about the plan, which is the National Mental Health Program, and the legislation also, like I have told you that the Mental Health Act, Care Act 2017 was passed, and it is being incorporated and followed by everyone, by every tertiary hospital also across India. And so as to conclude, we can say that the national, can you hear me?
Yes,
Am
ma'am.
I audible?
Yes, ma'am. Yes, ma'am.
As a conclusion, you can see the national health policy aimed at doing the greatest good to the largest number through 5 interdependent and to be implemented, like the extension of basic mental health care facilities at the primary level, like I talked about, and also the strengthening of psychiatric training in medical colleges at the undergraduate as well as postgraduate levels. While being working in the RML hospital, I can say that we have incorporated well in our hospital, and also the strength, the modernization and rationalization of mental hospitals to develop them into the tertiary care centers of excellence. So now you must have heard that a lot of hospitals, they are just moving ahead for making them center of excellence in mental health. So we can also conclude that the empowerment of central and state mental health authorities for effective monitoring, regulation, and planning of mental health care delivery system in frontier areas to evolve better and more cost-effective therapeutic interventions, as well as to generate, some inputs for future planning. So that was the whole idea about this national mental health policy. So if you will see, if you will ask me that, what is the prevalence of mental health disorder? So research says that the mental health disorders, the diagnosable mental health conditions, they are existing, they are around 5 to 7, 6 to 7%. But this policy is not only talking about people who have been diagnosed with this disorder. And just let me tell you that this research data is not the accurate data, because because of the negligence, because of lack of awareness, because of stigma, a lot of people, they just don't reach. They don't. So this problem is underreported. One, two, we are not concerned for the mental health disorder. Why we will wait till the time is getting, the person is getting or been diagnosed with some mental health disorder. So we need to address those issues at the very basic level. You know that the 40% of our population is of adolescent and children. So if you are addressing this, the school mental health program is one of the very important program for the national mental health program. They have talked about, I am the expert member, and we have developed many modules for the training of teachers. The whole idea for that one, that there was a scarcity of mental health professionals. So we will train the teachers. So at this crucial age, because research data says that 50% of mental health disorders, they emerge in the childhood, because of many, it may be any trauma, it may be physical abuse, it may be social abuse, sexual abuse, emotional abuse, bullying, or the ill treatment by anyone in the environment, bullying at the family level also. sometimes the family members also, they pass critical comment. So 70%, 75% of diagnosable disorders, they take place in the adolescence only. So that is something, if we are targeting that part. So, and it's not only that we are screening the children and adolescents who have been diagnosed with mental health disorder, because the prevalence among the children and adolescents is 10 to 15, 12 WHO data in India. But we have to talk about the promotion of mental health services. So, like a lot of CBSE board has been given to the life skill training program. So we are training our, the future of our, who are the future leaders of our country. We are training them for incorporating skills in the child to develop their critical thinking, their emotional regulation, that they are not easily emotionally frustrated. They have, better, they can have better their decision making, better problem solving skills. They can have better negotiative skills. They have
Dr. Rushi,
so
Dr.
IQ is not
Rushi.
important. EQ is important.
Dr. Rushi, thank you very much.
Yes.
It's really
Yeah.
interesting topic you had, but we have one another
There is a
team
lot to
waiting for.
summarize that there is a
Thank
lot
you.
to
Yeah.
do.
Thank you so much, Dr.
When
Rushi,
we
for
talk
such an
about the promotion
informative
of mental
and
health services. Thank
insightful
you so
session,
much.
right from the intent of the policy to discussing the drawbacks. I wish we had more time to hear about it, because this is such a relevant topic for especially, population in India and, mental health. Next, but we have another team of presenters
so
as well.
much.
Probably we'll take it up in the question and answer session. I'm sure most of the attendees would have questions for you as well. So next I would like to invite Project Sangath team to present their work, moving from government's perspective on mental health to non-government initiatives. I invite Mr. Deepak to present their work, please.
Good morning, and thank you, Dr. Pooja. And a special thanks to Dr. Kamlesh Singh and the organizing committee for giving us the opportunity to present our work. I believe now we only have 10 minutes to complete our presentation. And then we will try to be try to be precise and optimize the time that we have available with us to complete our presentation, so that at least we have to do 5 minutes for the questions if any of the attendees are having. Now I'll request my colleague Lochin to share the screen so that I can quickly take you all through the work which we are doing.
Mr. Deepak, you can take 15 minutes. Due to the technical problems we faced earlier with Dr. Rushi, we've extended this session for 10 minutes. So we would really love to hear from you. So yes, over to you. Thank you.
Lochin, can you share your screen, because I can't see it.
Yeah, I'm trying to share the screen.
In the time that Lochin is trying to share the screen, I would like to make an announcement for the participants who have a question. They can start typing in their Q&A block, and we'll have them all together after project team, the Sangath team presents. So you can start putting your question answers in the Q&A box, your questions, and we'll take them all together in the end.
Can you see my screen now?
Not yet.
Okay.
Okay, no problem. Let me try and then share screen. Can you please stop share, Lochin?
Yeah.
Okay. I hope you can see my screen now.
Yes, sir.
Okay.
Yes, your screen is.
Okay, thank you very much. So a brief about Sangath. So as you mentioned in the beginning, that Sangath is a not-for-profit research organization. We started in 1996 in Goa. It is co-founded by Professor Vikram Patel, who is based at Harvard since last 5 years. And it was Goa's first multidisciplinary child development clinic. And now we have been in one of the most recognized mental health research NGOs. Our headquarters is in Goa, but we have hubs in Bhopal for Central India, Pune, and New Delhi for the North India region. We work in partnership with several state governments. So we are having presence in around 13 state of the country. We are having memorandum of understanding with the National Health System Resource Center, Government of India, as well as with the National Health Mission and Department of Public Health and Family Welfare of these different states. We are committed to improve health across the lifespan by empowering existing community resources to provide appropriate physical, psychological, and social therapies. And our primary focus areas include child development, adolescent, and youth health, which is being led by our Delhi Hub. And when it comes to the adult mental health and the digital mental health, we took at the Bhopal Hub. And when it comes to the addiction research and adolescent research, then our Goa Hub is leading the work. We believe and we know that providing mental health care services to our people is not going to be easy. And if you want to go ahead with the vision that we want to provide this kind of services with having psychiatrists in place, then this is not going to be possible in a country like ours. And we have generated evidence a decade ago that the task sharing approaches are the way to move forward, where we train the other healthcare providers such as physicians, nurses, ASHA workers, ANMs, and community health officers. We have shown the effectiveness of these brief psychosocial interventions in the past. At the Bhopal Hub, we started in 2011 by having a memorandum of understanding with Directorate of Health Services, Government of Madhya Pradesh. We developed the mental health care plan for the Sehot district of the state, and then integrated the mental health care services into primary care settings, specifically at the community health center level. And we have supported the the National Health Mission, Government of Madhya Pradesh, in scaling up this model throughout the state under the Soham initiative. We have designed the model we named Man Kaksh. Man means the heart. Kaksh means a place where you can share your thoughts, your issues, your concerns, and you can receive help and support, which we started in 2013. And this was done under the prime work funded by defeat grant. And the model was effective, where we trained one medical officer, a physician, on WHO MHGAP program. We have trained 2 nurses on screening, diagnosis, referral, documentation, and brief psychosocial education and training program called Healthy Activity Program. This model was effective. We proposed to the then Commissioner Health, Government of Madhya Pradesh. The government liked the program, and finally they scaled it up in the entire state at the district level. So whenever you visit next time to Madhya Pradesh, please visit Mankaksh at all the district health centers. And based on the initiative which we started, we have adapted, contextualized, and developed digital training interventions on healthy activity program for non-specialist health workers, for ASHA workers, for community volunteers. Now we are also planning to train the community health officers and have built the capacity of these healthcare providers. Successfully completed several large-scale implementation and randomized control trials since 2011. I'm only talking about the Bhopal hub. So we have completed several large-scale trials. We have a working memorandum of understanding with National Health System Resource Center, Government of India, Department of Public and Family Welfare, Government of Madhya Pradesh. Recently, since last 2 years, we have started working with the marginalized population, where we are working with trans persons, persons with special abilities, and we expertise and contribute for better healthcare access and quality care. The key impact being, as I said, the development of the Mankaksh model, where we have trained medical officers, nurses in the all then 51 districts. The dedicated budget for mental health care started. The dedicated senior health officers in the health department started based on the advocacy which we started. Regular reporting on key performance indicators started. The government of Madhya Pradesh, through their National Health Mission, received the Best Innovation Practice Award from Government of India in 2015 for the Mankaksh model. And our intervention has been scaled up in Gujarat, in USA, and other countries. Based on our advocacy with National Health System Resource Center, now we have patient health questionnaire, 2 items in the community-based assessment checklist, which is being used by ASHA workers in the community. We have several high-impact articles in peer-reviewed journals, including Lancet, Asian Journal of Psychiatry, and others. We have expertise in designing, developing, and implementing, as well as evaluating the digital training interventions to build the capacity of non-specialist health workers, primarily the ASHA worker, then ANMs, and then medical officer and nurses, generate evidence on innovative and scalable solutions to increase access to mental health care services, and then integrate these into the primary care setting, and then disseminating and doing policy advocacy. A brief about the projects that we have right now at the Sangath Bhopal Hub. We are having around 14 projects. Those have been funded. We have around 6 proposals. Those are currently under review. We receive funding from all the international and national institutions such as National Institute of Mental Health, Wellcome Trust, Johnson and Johnson, Grand Challenges Canada, Harvard University, Templeton World Charity Foundation, WHO Alliance, a recent grant which we received. All the details of these projects is available on our website, www.sangath.in/Bhopal. A brief about 3 project, the essence through which we started integration of these services into the primary care setting. The program is still going on. The SHARP program funded by Wellcome Trust, we are working with Beth Israel Medical School in Boston, AIMS in Bhopal, NIMHANS in Bengaluru, and we at Sangath Bhopal, first of its kind of study which we are doing with the patients suffering from schizophrenia. We are using active and passive data through smartphones, smartwatches, where we are using digital phenotyping and designing an algorithm to predict the relapse of schizophrenia. First of it is its kind in India. The second, the third, the second last, you can see the optimized DRO1, recently funded by National Institute of Mental Health, the government of USA, a 4-year study. Again, first of its kind globally, where we are working again with National Health Mission, government of Madhya Pradesh, AIMS Bhopal, Harvard Medical School, Vanderbilt University, Oxford University, and we are trying to develop an algorithm using machine learning, artificial intelligence, by doing digital phenotyping, DNA extraction, genomic analysis, and then predicting the treatment precision rule, where we can predict that with a specific set of characteristics, an individual will be responding to which kind of a treatment, whether it is going to be a medication or a psychosocial education. The WHO Alliance recently funded study where we will be working with the National Health Mission, government of Madhya Pradesh, to assess the adoption of the comprehensive primary health care NCD portal, both at the web version as well as the app version, which has been used in this state. In essence, we believe in partnership, where we work with the primarily with the NHSRC, Government of India, different state governments, NHM in Madhya Pradesh. We do have memorandum of understanding. We believe in creating a continuum of care, and through our programs, we have trained ASHA workers on screening, detection, and referral for mental health conditions. We have trained medical officers on diagnosis, prescription of antidepressant. We were able to get the antidepressants available at the primary healthcare centers, trained nurses and ANMs on screening, documentation, referral. Then through our Mankaksh model, we have these services available at the district level as well, where we do not have psychiatrists available. And through this kind of a model, we have been able to create a continuum of care starting from community to till the district level, and now working uh, with the apex and tertiary care institutions to use artificial intelligence and machine learning to generate algorithms and to create treatment precision rules. Now I'll request my colleague Azaz to uh, take over and take us through briefly about the project Anand, which is for ASHA workers, because we are working with them since last a year. We know that these were the women who led the war against COVID-19 in rural India. We have 1 million ASHA workers, critical for last mile care, affected by burnout, poor well-being, and demotivation. We have been receiving requests from ASHA worker and other non-specialist health workers since last 3 to 4 years that everyone, including the government, whether through their vertical and horizontal programs, the other not-for-profit research organization, for-profit research organization, they in their own terms, they dump everything onto us, but we are incentivized kid. We do not receive salary, and nobody is listening to us, and nobody is doing anything for us. Hence, we started Anand project, funded in 2021 by Temple World Charity Foundation. I'll request my colleague Azaz to speak more about the Anand study.
Mr. Deepak and Mr. Ejaz, can I make a polite request? We have another session starting at 11:45. So we have precisely 10 minutes left in between. If you can, make it a little concise, it'll be helpful. We would like to leave some, maybe 5-6 minutes for discussion at the end.
No problem, no problem.
Thank you so much. Thank you.
Over to you, Azaz.
Thank you, Deepak. Just I'll speak in a brief about Anand project. So Anand is a 3 years randomized control trial funded by Templeton Foundation, USA. The aim of Anand project is to design, develop, and deliver positive psychological based remote coaching intervention to ASHA workers to improve their well-being. As Deepak shared their status, like they were working hard in during COVID-19, and many research studies reported that high prevalence of burnout and stress among ASHA workers. So the Anand project is being implemented in Raisen district of Madhya Pradesh with collaboration of National Health Mission, National Health System, and resource centers. We also collaborated with Harvard Medical School, Bandit University, National Institute of Medical and Neurosciences, Parvara Institute of Medical Science, Maharashtra. So the Anand in remote coaching, the Anand remote coaching intervention based on positive psychology focuses on using character strength in negotiating daily life challenging and stressful situation, helping in managing relationship and handling burnout, as well as improving overall well-being. So ASHA workers are female community health workers, deliver maternal and child health care services in rural areas. They are incentive-based cadre of cadre of community health workers of national health missions. So we have 8 structured remote coaching calls. These coaching calls are delivered by coaches who are trained in Anand interventions. So we have adapted evidence-based strategies that helps to deal with routine life challenges. So we will have yes, we will have 44 ASHA workers in our trial. We will and they will be selected through randomization process and will be allocated in 2 arms, intervention arm and control arm. So intervention arm ASHAs will be receiving 8 remote coaching calls and 5 days residential coaching program. Where control arm ASHAs will not be receiving this intervention, and we will at the end of the intervention we will evaluate the effectiveness of the intervention based on deliver our coaching calls, and we will be evaluating burnout, their burnout well-being for measuring our effectiveness of our interventions. So Asha, Lochan, can you please? Okay. So we have developed our coaching programs, and we tested this with ASHA workers in development phase, and now we are piloting in Russian districts with 30 ASHA workers. So we have recruited 70 ASHA workers, and we allocated 35 ASHA workers in intervention arms and 35 for in control. So Lochan, can you please provide a status of the pilot now?
Sure. Thank you, Deepak and Ajaz. I'll take it forward considering the theme of the session, which is from the findings from the field. So right now we are in a stage where we are piloting our intervention, which is derived from the positive psychological framework. And most of it is the conceptualization and the strategies that are the core part of our intervention is um, driven from the literature, driven from the Western literature, most of it, but we are trying to apply it to the Indian setup is one of the big challenge that we would cite across, like while we are discussing this intervention and the progress about it. Specifically while talking about the strategies, and like you have also seen the project phases across. Uh, Starting from the formative findings itself, when we had the FGD sessions with the ashas, their experiences about identifying that as a burnout related issue or as a stressful situation, that itself was they realized that those are the stressors, but realizing what are the impacts that they're facing as while dealing with the stressors was something as a significant finding that we have found across FGDs. And also with respect to how they're coping with those situations, how they're coping with those stressors, how they're trying to manage those health related consequences or work life imbalances that they're facing across different domains of life. So that dynamics of stressors, burnout, and coping mechanisms, along with what we have also found across literature review, literature findings, gave us a better guideline towards understanding how that intervention could be rolled out, could be framed out while we are implementing it in a very Indian sort of setup, where it becomes a challenge also because some of the strategies do align with how their coping mechanisms were. For instance, about spirituality or use of the character strengths, or though they are not aware of those technicalities of the character strengths or those positive psychological concepts, but they do have their own mechanisms of dealing with or using the character strengths, and that we have come across quite evidently while we were piloting our intervention. If I briefly cite what we had while we were dealing with the literature review, we had a limited comprehensive we could trace back to the limited comprehensive understanding of how those interventions could be applied, because we were using a positive psychology framework and we have a totally different theoretical understanding in the Indian psychology, though they have the parallels across, but syncing a complete Western psychological framework to an Indian setup was a big challenge, and we had discussions around it. But while we were discussing those literature findings, that was a big challenge, because we also were not able to trace back to some good comprehensive intervention models to roll out for the ASHA workers. While, as I mentioned, while discussing for the FGDs, that was one of a very tricky situations, because they have their coping mechanisms and we have our strategies in the intervention. So aligning those two and providing that as an intervention model to the ASHA workers in an Indian setup, that interface was really interesting and also challenging for on the same hand. While we were developing the interventions, if I say, which was the phase when we starting from the March onwards, those PP frameworks, those strategies which we have identified in the literature, those strategies do have the parallels, but difficulty differentiating them and bringing out in a very in a very correct correct form so that it could be used up, it could be understandable, and it should not be more of a cognitive load for the ASHA workers. Should be something that they could practice in their daily life, something that they could easily get a hold of. Was the whole agenda. Again, a challenging point, but some modifications did happen over the course of time. While we were discussing, while we were having the pilot rolled out from November onwards, again it was an interesting phase, because we got to know of what strategies do they get a hold of, how do they understand those character strengths terminology, how do they bring it to their daily lives. And while we are having those remote coaching sessions, as Ajaz mentioned, uh, interestingly we are getting that dynamics of their understanding, their practice sessions, their those gaps also, of course, like how they're not practicing, how they're modifying it in practicing, again is one of the interesting thing that we have come across in the pilot. If I go to the next slide, Deepak. Yeah, so social demographic characteristics here we have put across, because while we are providing the remote coachings and while we are rolling out the intervention, the social demographic profile becomes one of the challenging components. Say if an ASHA is too experienced, and getting back them to understanding the basics of the concepts of what they really possess, like the character strengths, and then having them that hold of practicing it in their daily life while we are providing that remote coaching becomes one of the interesting challenge that the coaches have to deal with, and they're sort of providing that coaching sessions in a very tailored manner. Then with respect to number of children also, like because women, working women again becomes the core of not just their working life but also the community that they're working, because being the ASHA workers, they are having the community visits, and then while working they are also having their personal individual family life. So that balance, while having that intervention as a part of their own life, is also some interesting dynamic that we're coming across. And so therefore this social demographic profile plays a very, very significant role while we are having that tailored positive psychology intervention for ASHA workers. So here we have not detailed the significant findings that we are, because right now we are in the phase of it, but also we are having the manuscripts from the formative findings, which could help the readers and also the attendees here and the panelists to go and like in some time we will be having this in a published domain. So maybe this could be a good interesting read for all of you, where we in the first publication, the first manuscript, we are identifying their understanding, their perceptions about how they are coping with it, what are the stressors that they're facing throughout, and how they're dealing with it. So that's a very interesting FGD discussion that we have put across. Um, yeah, so right now we are also having some of the interesting presentations from the formative findings, and also from some of the interesting challenges and the findings from the field while we were conducting the pilot sessions, which would be presented sometime soon. Yeah, thank you so much.
Thank you. A lot of thanks to Team Sangath and also to Dr. Rushi for giving us insights into the mental health policy, and to Team Sangath for telling us, Project Sangath, for telling us about the kind of work that you're doing on the field, right? It gives us a practitioner-oriented perspective. So thanks a lot. So moving quickly to the question and answer session. So we do have a question for Dr. Rushi. If Dr. Rushi is around. Dr. Rushi, are you here? Okay, so it looks like there was a technical lag on Dr. Rushi's part, so she couldn't be here for the session. And special thanks to Project Sangath for really summing up all of your work in such short time span. And if anyone has any questions, you can please post it in the chat box. If not, we can wrap up the session. And so I'll wait for a minute more. If anyone has any questions, please, you can post them in the chat box. Else, I would request everyone to move to the parallel scientific sessions, which are beginning at 11:45. So see you all there. Thank you. Thank you, everyone.
Okay, thank you, everyone. Thank you, Dr. Kamlesh and the organizing committee.
Thank you, sir. Thanks a lot.